Welcome to the lecture for research methods. We'll be talking about some alternatives to traditional quantitative research. So first off, let's talk a little bit about why you might do this. So what are some reasons to look at alternatives? One of the primary reasons is when the goal of your research is exploratory in nature. If you don't have enough evidence, be it empirical or theoretical, to justify a clearly defined expectation of what's going to happen in a certain situation, when you just kind of want to know, well, I want to know what would happen in this situation, or I want to know what people do in this situation, or I want to know how this thing works. And I'm not sure, and you just want to kind of gather that those initial data. Alternatives to quantitative research, think qualitative type research might be more appropriate. Another reason to think about alternatives would be that researcher-clinician divide we've talked about before. Because some clinicians really aren't comfortable with quantitative research and feel that the methods employed result in information that's too distant from the real world. So there may be some alternative ways of gathering and looking at data that might be more palatable to clinicians and more likely to be incorporated into their own work and inform practice. Okay. A third reason would be if there's a question about process, really about how something works. So not just looking at is A related to B, or does A cause B? Are these two groups different? I'm wondering about, okay, in what ways does A cause B? If there is kind of a causal relationship there, how does that work? And that's something that can be hard to do with your traditional quantitative methods. And then last, sometimes there are kind of these dual goals of research and intervention. And so if kind of, again, this harkens back to the researcher-clinician divide. If a clinician wants to do research on his own work, frequently they're not going to want to use your traditional quantitative study, because it can be rather limiting in terms of doing your clinical work. So if you can have some less traditional approaches, might lend themselves better to looking at what you're doing and trying to figure out if you're being effective working with clients and what it is that you're doing that is effective. So there's still ways of doing that without relying on quantitative research. Okay. One of the main types of alternatives we'll talk about would be a large group of designs, generally referred to as single participant designs. Okay? And it's a bit of a misnomer because it's not necessarily n equals 1. It's not necessarily research with a single participant, but the level of analysis is at the single participant level, and usually it is a small number of participants, and maybe even just one participant. But you could have 4 participants, but if so, you're not comparing, okay, these two to these two. You're looking at each individual participant as an individual and how that individual changes over time as you're doing stuff to him or her, right? So these are typically experimental designs where you do have an independent variable and you are going to do something to them to see if it has an effect. Right? Single participant designs broadly have a long history going back to Ebbinghaus's work with memory, where he served as his own participant and kind of people say, oh, well, this research is soft and it's subjective, but much of what we know about memory, the early stuff we know about memory and the learning curve, comes from Ebbinghaus and single participant design. Skinner made substantial use of single participant designs with animals in the operant conditioning paradigm research. So it has been used extensively, and so it's not just kind of this wacky thing that isn't accepted. It does have a rich history in research, not just clinically. So let's talk a little bit about what it looks like, some of the features. One of the primary features of single participant designs is repeated measurement. Right? So just like in some quantitative research, if you're doing pre-post, right? If you do that, typically you're measuring before treatment one time, treating people, and then measuring one other time. Single participant design, because you don't have as many participants, you're going to make up for your lack of participants in terms of your confidence that that the change is attributable to the independent variable by gathering more measurements, right? So you're going to measure a whole lot of times. So if you're doing pre-post, you're not just going to measure one time to establish a pre-score, right? You have to establish these things called phases, right? So you have this baseline phase, your pre-test phase, and a phase has to have at least 3 points, right? So 3 points that are all similar to each other, that's a baseline. If 3 points are all over the place, then that's not a baseline yet. Something's going on, and if somebody is all over the place every time you're measuring them on some variable, then you probably can't do a single participant design. And a quantitative design probably wouldn't lend itself either. You probably have to figure something else out to figure out why is there so much variability going on, because we need some stability so that we can see when we introduce an independent variable, if there's a change, we're confident it's due to the independent variable, not just due to this random variability that was going on before, right? So we measure multiple times at baseline to establish a baseline phase, and then we also measure multiple times after and even during treatment to establish a treatment phase, right? So it's not just one-off; it's lots and lots of measurement. And as I kind of alluded to already, it's important to establish some level of stability. But stability doesn't necessarily mean no change, right? It could be no change where you have this level progression of behavior. So you're measuring a baseline and you're at 10, you're at 10, you're at 10, or maybe you're at 10, you're at 11, you're at 10. So that's pretty stable and that's level, and you have a baseline phase. Could also be we measuring you're at 10, you're at 11, you're at 12. That's also stability. If it's trending, that's a trend, right? If it's trending in a stable upward or downward trajectory, that's still a phase. And we can still look at, okay, if you were at a 10 and an 11 and a 12, and then we introduce treatment, and then after treatment you're at 12, 12, 12, that's a difference, right? The trend has changed. It stopped going up and it's leveled off. And it could do a lot of things. It could level off, it could decrease, it could become steeper. You know, you're at 10, 11, 12, and there's treatment, and you go 12, 14, 16. That's different, and you can look at differences in trends, right? So as long as there's stability in the measurement, we have confidence in drawing conclusions from the study. Okay, so repeated measurement is big. Obviously, participants serve as their own controls, and there are a variety of ways to do this. The simplest way to think about this is with your oh, we don't have it on here. I'll talk about it in a minute. Sorry, participants serve as their own controls. So we're not comparing, this one participant to this other participant. It's comparing each participant to his or her own self, which gives us a lot more power to see the effects of an independent variable. Okay, and to that end, there's a real emphasis on experimental replication. And this isn't replication like we think about when we're talking usually in the quantitative area. If we're talking about replication, we think, okay, you do a study and then do that study again. In single participant designs, experimental replication is talking about replicating the relationship between the independent variable and the dependent variable within one study. Right? So the simplest way to do that, so I was getting to before, is your ABA or reversible design. So A is your baseline phase. So no treatment. We're going to measure and we're going to show that it's flat, right? And you're low on something, right? You're low on scores of happiness. And then we introduce treatment, which is B, and we measure and we show, okay, now you're high. You're high on happiness. Things are better. And that's good. And we've kind of shown that the treatment is having an effect on your happiness. But we want to replicate that relationship. We want to have experimental replication. So now we take away treatment, and we hope to see that you go back to being sad again, right? So from A, no treatment, to B, treatment, back to A, or with withdrawal treatment, we should see you become less happy again, and be stably less happy, hopefully. But again, there are other ways to do that, you probably are already anticipating there may be some concerns about reversal design, but we'll get to that in a bit. But beyond experimental replication, another key feature of single participant designs is an emphasis and reliance on visual analysis of data. The studies are typically designed in ways where you don't need complicated inferential statistics that rely on probability to interpret and see if something had an effect. But you can visually inspect, some graphic representation of the data and say, oh, that worked, right? With this example here, we can kind of see that when we talked about where, somebody's low on something during treatment. They're all the scores are pretty close to the same as each other, and all the scores are pretty different from baseline. And then we go back and we take away treatment, and it's back to where it was, and it's stable. Looks like treatment has an effect on whatever it is we're measuring. And we don't need p-values or even effect sizes to figure that out. We can just look at the picture, which simplifies interpretation and makes it more likely probably that these data would be used by a clinician, because they don't need any kind of sophisticated statistical knowledge to understand the results of a study like this. Okay, getting back to kind of different ways that experimental replication takes place, kind of speaks to the different types of single participant designs. The one we talked about today is the ABA or ABAB. Usually we don't treat people, take it away, and then quit the study. We will give treatment back, right? That's the B. And we want to show that we have power over the behavior, over the dependent variable that we're measuring this whole time, such that when we give you the treatment, you get better. We take treatment away, you get worse. And we want to be able to demonstrate that we have power. But if we demonstrate that, then there is strong evidence of an effect of the IV on the DV. But there's sometimes problems with that. Obviously, one would be the ethics of doing that. And the other, just kind of from an experimental point of view, is sometimes the effect of treatment may not be reversible. Right? Especially think about some treatments you're hopefully learning about. You should hope that, okay, if somebody comes in with depression and I teach them some skills, maybe some cognitive restructuring skills, and their depression lessens, right? They get happier. If I stop teaching them that, hopefully they won't suddenly go back to being depressed, right? Because the idea is that we're going to have these therapeutic experiences and they're not going to need us anymore, so that we can stop and they won't get depressed again. So sometimes this isn't feasible or practical. Usually more effective for real behavioral stuff. If we have a kid who's acting up at home, maybe, and you say, well, I think maybe they're doing it for attention, and so we want to increase positive attention. So you measure misbehavior, and then you have the parent increase positive attention for a week. We measure behavior, so that all of a sudden we see behaviors going down. So, okay, wow, they're doing really great. Okay, mom, dad, I know you don't want to do this because things are going well, but to really be confident that this is what's going to help you, I want you to stop giving that positive attention. Right? So go back to what you were doing before, and let's see if those misbehaviors come back. And if they do, then okay, yeah, now we know. Give the positive attention, and everything's going to be okay. Right? So that would be an example of a simple ABA reversal design. You might also want to do something a little bit more sophisticated, right? A phase change design. And this is one of kind of the really cool things about doing single participant designs, and one of the reasons I think it's important to learn about, because it's kind of stuff you should probably do in your own practice, where people come in and you're going to do some assessment at some level, even if it's not formal. You're going to have some interviews, and you're going to have some idea of their symptom level, baseline, coming in to see you, and then you're going to start treatment. And again, if you're a good clinician, at some level you'll be assessing how well are they doing. And so you have the treatment B. If treatment B is not working, so let's say the depression is still at the same level it was when they came in, it's still at the A level, now you say, okay, I'll try this other treatment, which is the B1. And if the B1 works, now they're getting better, we can stop providing B1 and see if they get worse again. So it's just a little bit more than a simple reversal. But it kind of points to the flexibility of this type of design, to where you don't have to go and say, okay, this is the procedure I'm going to go in, I'm going to do exactly this, and we're going to see, and and then we'll collect the data, and we'll see if there's an effect. With single participant designs, you can change the procedure going through. So, we're doing this treatment. It wasn't working, and we didn't just stop the study. We said, okay, let's try this other treatment now, and we'll continue measuring. And you can still collect data within that same study. Another possibility would be doing something like component analysis, also referred to as dismantling. This is particularly helpful when you're doing any kind of multi-component treatment. So maybe you're doing EMDR with progressive muscle relaxation, and you want to know, and maybe you people found that it works, but you want to know, okay, well, do I need to do both of those, or can I just do one of them? And usually it's the insurance company that wants to know if you can do less. But there may be some scientific or other clinical reason why it may be impractical to kind of deliver the full set of services that we know works. So we need to know, okay, well, what are the essential components? So component analysis says, okay, well, let's look at that. So you deliver the whole treatment. So here, component B plus component C, deliver both components together, and then take away one component, just give B, and then put C back, take away B, and then put B back, right? And the whole time we're measuring behavior. We're getting at least 3 points in time to establish a phase, and we can see when are they getting better, when are they getting worse, and we can get an idea of what component is having the strongest effect on the dependent variable. So these are all kind of variants of the first one, the reversal, right? Where we're doing stuff, taking it away, or changing and seeing what happens. And again, that can be problems because sometimes the treatment's not reversible, sometimes it's unethical or impractical to take away or change the treatment. So another way of doing single participant designs that, if those are concerns, would be to do some type of a multiple baseline design. And there are lots of ways of doing this. One would be across behaviors. So think about establishing a baseline for some problem behavior. So if we've got a kid who is tantruming and also is violent with a sibling, right? So we measure both of those things, and we give baselines on both of those behaviors, and we start treatment, and we have some intervention, and we just target one of the behaviors. We just target the tantrum, and we don't target the hitting. But we keep measure hitting. So hopefully, if, again, depending on what type of treatment you're doing, if it's a very specific treatment, then you should see the one you're targeting go down and the other one not change. And then you start targeting the other one, and it should suddenly start to change. If so, you've proven, you've given some strong evidence that your treatment has an effect on these behaviors. And so the idea here being, again, you should only see a change in behavior when it's being treated. Which, again, depending on treatment, may or may not be true, because hopefully some treatments will have kind of these generalization effects. But sometimes that's not the case. And if not, we can kind of again show this kind of experimental power. Other than across behaviors would be across participants. So again, a single participant design with more than one participant, where you have 2 people with similar problems maybe, and you measure them both, and then you start treatment with one after starting treatment with another, right? So the one that you started treatment with first should show improvement before the other one, right? If they show improvement at the same time and you started treatment at different times, then it's not your treatment that had an effect. There's some other effect out in the world. Maybe the stock market went up 1,000 points or whatever, and that made everybody happier, right? But if the changes in each individual coincide with the time at which you started treatment with each individual, then you have more confidence, again, in the effect of the IV on the DV. And the last type of multiple baseline design would be across situations, which is similar to across behaviors. This is when maybe there's one particular behavior that you're targeting, and be panic attacks. They have panic attacks that occur sometimes when they're at the mall, sometimes they have panic attacks when they're at work, and maybe you start treating and you focus treatment on panic attacks at the mall, and you see those decrease, but the work ones don't decrease, and then you start on the work later, so we have another baseline, and then those decrease. Now we've shown again this kind of experimental control over the behavior of panic attacks. Okay, so these are different types of single participant designs, which again, a lot of flexibility, kind of can practically be used by clinicians just to see if you're doing, if what you're doing is working, right? Very kind of straightforward design stuff. Some limitations in terms of contributing to the scientific literature. There's some concerns about the generalizability of the findings, and again, this goes back to that discussion of, well, what do you mean by generalizability? Do you want to generalize these data? Do you want to generalize, or do you want to generalize theory? And the results of a single participant design may not generalize very far beyond the setting in which it occurred, but if it supports a theory or fails to support a theory, then that does probably have an impact on the generalizability of that theory. Right? Another thing to kind of be thinking about is sometimes we're not sure what the effect will be of multiple measurements. Again, because remember, that's one of the key components of single participant design, is measuring people lots of times. So even if we weren't doing interventions, measuring people a lot of times might have an effect on their behavior. If we ask you, are you depressed, every day for a month, you're probably going to change your answer just because we've asked you that many times, right? So, and there are different types of effects of measurement. Could be a kind of a reactivity, could be a sensitization, could be a fatigue. We don't necessarily know, and that might limit some of the conclusions you could draw from single participant design. Okay, and then another alternative to quantitative research, kind of another broad umbrella of several research paradigms, would be qualitative research. Now, qualitative research differs from quantitative, as the name kind of implies, looking at the quality of things instead of the quantity. So, not so much looking at numbers, not using typically statistical tests, but generally conducting some observation, gathering data somehow, usually in an informal way, and then providing a narrative summary of that tells people the meaning of those observations. Now, there's a trend, if you're reading qualitative research lately, toward kind of a qual hybrid, where they have these narrative summaries, but then they start applying quantitative analyses to them, right? So, somebody may have you may have a client, journaling, and if you read the journal and you kind of write, okay, over time the themes that emerge were this, this, and this. That's very kind of qualitative research. Now people are going toward, okay, they do that, then they'll also go through and there's this software they can use to go through, and the computer can pick out how many times certain words appeared and look at the likelihood of the number of times that word appeared for this person versus another person, and then compare those frequencies, which starts to get to be more kind of numerical and a little more quantitative. And there seems to be a trend toward, again, this kind of hybrid model, which is probably good. In terms of different types of methods of qualitative research, there are many. One, which you're probably familiar with, would be the case study, which is in some ways similar to a single participant design, but because you're often working with one or a small number of people. The difference here when we talk about case studies and not a single participant experimental design is, with a case study you typically are just gathering lots and lots of information, but not kind of numerical, measurable data. So this might be just looking over your progress notes with a client over time and reading through those, and then going to write a paper on that about the experience of this client and the themes that emerged, typically, how theory might apply. That would be could contribute to the research literature. Another method is commonly used, focus groups. So getting people with usually with some similar experience, maybe getting a group of school teachers together, or firefighters, or victims of trauma, whatever it is you're interested in, and having them talk about some subject, and you may be in there as an interviewer, and then again looking at what themes emerge, looking at interpersonal dynamics, and trying to answer some question about people. Usually some sort of observation. Qualitative research may involve participant observation. Right, so if you wanted to do research on Alcoholics Anonymous, one way to do that would be to go to AA meetings, and if you're a participant observer, then you would stand up and introduce yourself. Hi, I'm Dr. Fiala, and I'm an alcoholic. Right? And you would be part of the group as you were observing the group. And then related to that would be direct observation, where you're a participant, you're more distal from the data, and you're just observing it, but you are observing it directly, although you're not participating with others in the interaction. So these are some different ways of doing qualitative research, which again can generate valuable insights. And for me, I think of it as kind of a good starting point for generating hypotheses and trying to figure out, okay, what might be going on here, and then I want to go back and document, okay, because I'm not really that confident in the results of my qualitative research, but okay, here's a hypothesis that emerged from doing this qualitative study. Now I want to go confirm it with a quantitative study. I'm going to gather, participants, use my random assignment type of thing. But that kind of speaks to the tension between quantitative and qualitative research. In quantitative research, proponents of qualitative research say, well, the meaning is lost in the numbers. You have these p-values and you're focused on all these things, but you don't really know what's going on with the people in your study. You don't know what the quality of their experience is like. Just because you know that their average BDI score was 22, you don't know what their depression was like. Right? You can't tell me anything about their sadness or the depth of it or anything like that. All you can tell me is this very kind of numerical stuff. And somebody doing qualitative research would say, that's what I'm really interested in. I want to know about these people's experiences. And that's a fair argument. On the other side, quantitative researchers might criticize qualitative research and say, well, is the meaning generated subjective? Because if we don't use these arguably more objective numerical approaches, then, because typically what you do with qualitative research again is you identify themes that emerge from the data, and it could be argued, well, if that one researcher thought those were the themes, maybe they weren't the themes. And again, there are ways to make it less subjective, where you have a group of people trying to decide what the themes are, and you look at inter-rater agreement, and if everybody agrees that there were these four themes emerged, then that's less subjective, more objective, at least some shared subjectivity. But both types of research have a place. They come from different traditions. Unfortunately, too often they run parallel tracks and don't intersect. Our field would probably move forward much more quickly if there were more intersection between the two, and not just qualitative informing quantitative, but also quantitative feeding back on qualitative research to point towards new things to look at, and maybe verifying the real world validity of some of the things we find using quantitative research. Okay? Take care.